In today's case, we will be looking over a case of a right-sided hip joint pain in a 20-year-old female. So the patient had been complaining of hip joint pain since last 1 month, and for which the patient had been referred for the MRI. So we'll go through this MRI. So this is an axial PDFS sequences. What we need to look in a 20-year-old patient would be the bony areas. Are there any marrow edema? Is the joint proper? Is the alignment proper? Any type of impingement is there? Any type of neural pathology, neural compression is there? Any soft tissue lesion is there? What is the overall type of morphology of the femoral heads and neck? Are there any osteophytes? Is there any labral tear? Any muscle atrophy? Any muscle edema? These are the sort of things that we need to look at. So first we'll go systematically. We'll look at the joints. So this is the right hip joint. No joint effusion, synovitis. Same thing goes on the other side as well. No joint effusion or synovitis. Now looking towards the pubic symphysis, similarly no edema, no symphysitis, and the sacroiliac joints, they also appear normal. On the first look, we'll now go and see the bones. So bones will evaluate on T1 weighted sequences. So we'll T1 weighted sequences help us pick up the pathology better. Usually it appears hypointense, the pathology, so we'll be able to pinpoint it fast. In this scan, we are not able to see any type of pathology which is abnormal, any abnormal hypointense signals. So we'll again see a PDFS sequence to see whether there is any edema anywhere, but no marrow edema is there. So now we'll look at the tendons, the attachments. So the major ones which are the ones to cause pain and any discomfort would be the attachment on the anterosuperior iliac spine, that would be the sartorius. Then going on to the anteroinferior iliac spine, it would be the rectus femoris. Then coming on to the posterior aspect, we have got the hamstring tendon attachment. So these are the usual usual suspects that we see. And on the greater tuberosity, we'll be able to see the gluteal tendons inserting, whether there is any greater trochanteric bursitis. Here in this case, we are not able to see any bursitis as well. So we'll just have a look at the axial sequences for the muscle edema. Any muscle edema, discontinuity, disruption is there? Nothing of that sort. So now let's come to the pathology. Here we are able to see some kind of a bony outgrowth which is occurring onto the posteromedial aspect of the proximal femur in the region of the lesser tuberosity. This outgrowth is showing continuity with the medullary canal as well as the cortex. So based on this, we'll diagnose it to be an osteochondroma. For it to be an osteochondroma, it needs a cartilage cap. So this is the cartilage cap of the lesion. So in an elderly individual or the ones where the growth has stopped, usually the cartilage plate is very thin. And in this case as well, we are able to see a very thin sliver of the cartilage cap which appears hyper intense. So this is definitely a benign type of osteochondroma. I'll just show it on the coronal images as well. On the coronal image, we are able to see this better. I'll show the zoomed out version of this, and here we are able to see the bizarre shape that it takes. Osteochondromas usually take these shapes. So the things that cause concern in cases of osteochondroma is increase in size, development of pain, increase in the cartilage cap thickness, usually more than 2 centimeters when measured along the axis of the growth. Then any edema, any subtrochanteric or any bursal formation, that is pseudo bursa formation because of the frictions. And most of the time it is not the lesion itself which is the cause of pain like in this case, but it is the location. So here we are seeing that there is a reduction in the distance between the femoral neck and the ischial tuberosity. So this would be the cause of ischiofemoral impingement. Because of this impingement, there is a reduction in the distance and there is subtle edema in the muscle. So this type of pathology, based on the occurrence where the osteochondroma arises. Sometimes it causes narrowing of the joint space, sometimes it causes friction, sometimes it leads to a bursa formation. In this case, it is causing ischiofemoral impingement. Usually the diagnostic criteria for saying whether there is narrowing or not is to say if it is less than 10 millimeter. So here it is 23 millimeters. If it becomes less than 10 it would become narrowed. So in this case it is 5 millimeter. However, there is no fatty atrophy of the muscle, quadratus femoris muscle. So this would be just a cause of pain or impingement which has led the patient to get an MRI done. Thank you.